Hello, and welcome to today's webinar, Medicare Advantage Star Ratings, Strategy for Optimization. We're very fortunate to have with us today Kevin Ruane, who leads Meritive's Analytics Advisory Practice, Susanna Grace Tritt, Senior Consulting Actuary at Wakely, and Daniela Simpson, Senior Consultant also at Wakely. At this time, I'd like to turn the floor over to the speakers.
Great, thank you so much. Appreciate everyone joining us. Hope we have a great session today on Medicare Advantage Stars Rating Strategies. I'm Kevin Ruane, as the speaker had said. I work for Merative and I'm the practice leader there. Been with the company about 18 years, started my career on the health plan side. I'm very excited to meet with you today and to discuss stars and strategy. Let me just go through really quick. We were fortunate enough to have our actuarial partners here, Wakely Consulting, so Susanna Grace and Daniela, who will introduce themselves when they start their section. But I am very honored to have them with us today. They are a very strong partner for us. I did just want to give you a little bit background on our two companies before we dive in. So again, Wakely is a premier healthcare actuary company consulting all things actuarial consulting from rate setting, Medicare Advantage, Medicaid, ACA. They are specialists in risk adjustment. You will see their stars prowess today. Again, it's going to be a great session. So we have their contact information at the end, and we have this deck will be going out with their expertise. And then just a little bit of background on Merative as well. Merative is a new name, and hopefully you're all familiar at this point. We've been Merative for about a year and a half. But we've been in the industry for 40 plus years. You may know us previously as IBM Watson Health or Truven. We work with clients and have been working with clients for 40 plus years across the healthcare ecosystem, providers, employers, payers. We work with 7 out of the top 10 US payers, and we're doing all things analytics, including stars that we're talking about today, but everything from controlling risk and affordability to compliance to the member experience, provider profiling. Again, we'll just take a deep dive into stars today and show some of the strategies that we're deploying with clients, as well as things that are coming down the pike. So introductions went through. We will give an overview of the 24 star ratings that just came out a couple weeks ago. So we're going to unpack that. What's coming next? And we want to be on top of all the upcoming changes, the dynamic environment for sure, as well as reporting optimization, right? The analytics key driving impact. And then we will wrap up. Again, this will be recorded. So hoping to have a great session today. One thing I did just want to start with what stars is. And I'm well aware that there are many experts on the phone, but we do have people that call in who aren't familiar. So I thought I'd just start with what stars is, knowing full well. We will be going deep on this call, but just to level set. So the stars ratings are for the Medicare Advantage and Medicare Part D plans. It's been around for a couple decades, since 2007, and it's meant to rate the plans for quality to drive consumer choice, right? Everything from a 5-star excellent plan to 1-star poor. And there's different categories for this, from staying healthy, screenings, tests, vaccines, chronic conditions, customer service, health plan complaints, drug pricing, and patient safety. So it runs the gamut. This is changing over time, and that's what we'll be going through. The weighting for these measures and measures come on and drop off, and the way the measures are administered. But it's a big deal. So we want to kind of go through this, and these are all things the health plans are focused on anyway, right? But this rating system is what we're going to take a deep dive on today. It drives a lot. And again, this just came out a couple weeks ago, but this is published every fall, gets a lot of press, and it is going to drive your enrollment as well, as those familiar with stars know. Just to set the stage for just the environment we live in before we take a deep dive in the stars. I mean, we do have an aging population. You know, here we have 1 in 6 people are over the age of 65, according to the 2020 U.S. Census. In 1920, it was less than 1 in 20, right? So it's a changing environment for sure. You know, driven largely, a big piece is the aging of baby boomers. That's a big piece. People are having less children. There are huge advancements in medical technology and pharmacy and vaccine. It's all impacting the growing number of people over the age of 65. So that's, again, another reason to focus on STARS and Medicare Advantage. In addition to just the growth of people over 65 in the population in general, Medicare Advantage is growing, and it has been growing for some time. This past year, in 2023, it did hit over half of the Medicare eligible people were enrolled in Medicare Advantage versus Medicare proper. And, if you look 10 years ago, in 2013, it was 29%, right? So it went from 29% to 51. And even looking at a couple of years ago, projections of what 23 or 24 would be, it's outpacing those projections. So the growth in Medicare Advantage has been very, very large. 7 in 10 in 2023 of the Medicare Advantage enrollees are enrolled in high-performing plans with 4 or more stars, and doing what it's supposed to be doing. There are less higher star plans, less 5-star plans. So actually, the 71% here, 7 in 10, is less than it was the year before, and that's something we want to talk about. In 2024, only 31 plans got 5-star accreditation versus 57 in 2023 and 74 in 2022. Again, just setting the stage for the reason, even more so for the laser focus on STARS measures and optimization before we kind of kick off. And then again, this won't be news to those who live and breathe STARS, but there is, very big impacts for the health plans, right? So the quality bonus payments, we're talking billions of dollars in payments that go to the high-performing plans. You have the high-performing icon that is going to drive your membership. That for the 5-star plans, there's a special enrollment period for 5-star plans. And the low-performing icon for plans who have less than 3 stars for more than 3 years in a row, not a good sign to have next to your plan, as well as they're not allowed to have service area expansion. So when we're talking about all this, we're talking about your profitability, we're talking about your enrollment, you're talking about your growth and credibility as well. This picks up a ton of press. So even outside, Medicare Advantage specific, all of this good news, if you're a high performer, or the other news, is in the press, right? So there's a big impact far and wide. So I hope to have a great session today to talk through strategies. And to start that off, I am going to turn it over to Susanna Grace, who is going to unpack 2024 for us. Susanna Grace.
Great. Thank you very much, Kevin. I am, as Kevin mentioned, a senior consulting actuary with Wakely Consulting Group. I've been with Wakely since 2016, and I'm located in our Denver, Colorado office. So what I'll do first is a very quick high-level coverage of the 2024 star ratings, and then we're going to jump into the Tukey, what some have called Tukey Gate. I don't know if I'd go that far, but we'll jump into the impacts of Tukey explicitly. But to start off, I just want to quickly remind everyone of what we're talking about. So I'm going to touch on 2024 star ratings. My associate Daniela will get into some future changes. But when we talk about 2024 star ratings, we're really talking about 2022 measurement year performance, because there is such a lag in the time that the data is sort of gathered and collected, submitted to CMS, reported out by CMS, and then impacting plans. So 2024 star ratings are already 2 years lagged from what is intended to be the year they are measuring, and they will not impact payments until 2025. So for those of you who are involved in bids, Medicare benefit discussions, Medicare marketing discussions, all of that stuff is going to be impacted in the next 6 to 8 months by what just came out 3 weeks ago, by these 2024 star ratings. All right, so let's talk about what came out in 2024. This is in the industry that moves really quickly and stock prices that change very quickly. At this point, old news, but I'll just touch quickly on the general trends for those of you who may not have been, following it quite as closely. In general, between 2023 and 2024 star ratings, the average star rating dropped from 4.14 to 4.04. That is important because that means there are less contracts above 4 stars, which is the level at which plans receive the 5% quality bonus payment. So you're going to see in this deck, I'm going to talk a lot about 4+ star plans because that is such a big break point for plans. So there's less plans above that level. But the big reason for that is actually the decline in five-star contract enrollment. As Kevin mentioned, five-star contracts can receive this special enrollment treatment where members can move into those contracts throughout the year at any time, not just during the open enrollment period. So the decline in enrollment in that contract, that type of contract, means there are likely to be less movements mid-year in 2025. I'm sorry, 2024. The overall decline in 4+ star enrollment is from 21 million to 20 million. Although you see an increase in 4.5 and 4-star plans, that's not overcoming that decline in 5-star enrollment. And that the largest driver of that decline is this change in the methodology that CMS is employing. That's the Tukey change that we'll talk about a little bit more. But that general decline in 4+ star enrollment overall means that there will be a decline in quality-based payments in 2025. I won't spend much time on this slide. The only real takeaway here is that when we look at the measures underlying the overall star ratings, they're not being impacted equivalently. We know there's a general decline in star ratings, and so a general, on average, decline across these measures, but it's not equal. So where we're seeing the largest decline is in those measures capturing access. That is a lot of CAHPS measures. The drop in individual measures is also partially offset by an increase in the improvement measures. We did not see an impact when we studied the Tukey impacts in improvement. So this is not due or because of Tukey. This is just plans generally improving. It's not also measured at the measurable star rating level. So this is saying plans are actually improving in their measure rates. When we look at the overall star rating changes and just break contracts out into whether they decreased in star rating from the prior year, from 2023 to 2024, whether they did not change at all, so a 4-star contract would stay at a 4, or whether they increased in star rating, we see a divergence in how that looks between all the contracts across the country and SNP contracts alone. So just focusing on the left side of this chart, that pink bar is showing that 40% of enrollment today is in a contract that's about to drop in star rating. And that's going to have real implications on how plans structure their benefits, what margins they're making, all types of things for the actuaries in the room for how you're going to be working on bids next year. There's a large proportion of enrollment in contracts today that are about to struggle to hold on to all that they're offering. But when we look at SNPs, that is far less. So that's 20% of enrollment is only in a contract that's dropping. This may be because SNP contracts tend to run lower to begin with, but it's an interesting finding because it's unique in that it's not what we found in other years, where we see SNPs tend to get sort of impacted more by some of these changes. So this is another result that's been sort of published elsewhere, so I won't spend a ton of time on it. But when we look at the top 10 parent organizations in terms of enrollment in Medicare Advantage plans overall, and we then look at their enrollment in 4+ star contracts, again, 4+ being that big dividing line on quality-based payments. It's sort of where the gold star in the star ratings because it has such a big implication for revenue. When we look at their enrollment in 4-star contracts, we do see several of them dropping. United, Anthem, and Kaiser in particular are dropping in 4+ star contract enrollment. There's been a lot of news about Kaiser dropping out of 5 stars. This is not what that is showing. This is actually showing Kaiser dropping some enrollment out of 4 and up stars, which is, in my 5+ years of working in stars, the first time I've seen that happen. So I think it's just even a bigger indication that some of the changes that CMS has put in place and will continue to change in the future, that's going to be sort of creating an uphill battle for star ratings. I guess it comes for us all, even those that really excel in star ratings like Kaiser. On the other side, CVS/Aetna, that's one organization, I'll just refer to them as CVS, them and Guidewall have significantly improved, which is sort of bucking the general trend that we've seen across the country. Those two did actually decline from 2022 to 2023. So that improvement in 2024 is actually sort of closely brings them back to where they actually were before. So I'm not going to touch on all the upcoming star ratings. This slide is just intended to say we're not done. CMS has made a lot of made a big star rating change for 2024 star ratings. They will continue to be making changes that are going to have generally a negative impact on Medicare spend. And a negative impact on Medicare spend means a decline in star ratings. It means generally less revenue for plans to have based on those quality bonus payments. But right now, I'm just going to talk about 2024 star rating change that's highlighted here, which is the introduction of the Tukey outer-fits outlier deletion methodology. It's a bit of a mouthful, so I'll just refer to it as Tukey going forward. So the Tukey outlier deletion methodology, as I mentioned, it impacts 2024 star ratings for the first time. The intention of putting Tukey in was to increase the predictability of non-CAPS measures. So a lot of plans have complained about the volatility of cut points from year to year. It's very hard to aim for where you want to be on star ratings if you don't know what the break point is for those at the measure level. So you don't know how to get to 3 stars in certain measures or 4 stars in certain measures. Those cut points change year to year, and they were having some very wild swings. So CMS introduced this method, this sort of change, with the intention of making that more stable going forward. It impacts pretty much all measures except for those CAPS measures. When applying Tukey, CMS essentially removes outlying contracts prior to developing the cut points. So they look for contracts that are sort of out in left field, take them out of the mix, and then run cut points so that you're hopefully just not getting these wild swings year to year from these contracts coming in and out, or these rogue contracts that are sort of moving around far outside the pack. What happens when they do that is that they generally remove far more low-performing contracts than high-performing contracts from the pack. So that has the effect of moving cut points generally up. Not in all cases, but far more cases, it moves things up rather than down. So when you move cut points up, it makes it harder for plans to get to that level, and therefore harder to make that star rating in a particular measure, and then brings down generally their overall star rating. So what we did was we took the 2023 results. CMS had also published Tukey simulated cut points. So we reran all 2023 star ratings with the Tukey simulated cut points and said, what is the impact of Tukey alone? That is not the same as looking at 2023 to 2024 star rating changes. There's a lot going on between 23 and 24, including a change in measurement year. So there's just too many changes looking at year to year to isolate that impact. So by looking at 2023 alone with that one change, we are able to isolate the impact of Tukey. As I mentioned earlier, overall star ratings 23 to 2024 went from 4.14 to 4.04. That's the next to bottom row on this chart. But if you look at the middle section, the impact of Tukey alone would have brought the star ratings down to 3.94, pretty much doubling that decline that we're already seeing. So while the news of the day has been Tukey was big, Tukey was bad, Tukey was not as bad as it could have been. That is due to some very large organizations sort of offsetting that impact that would have been bigger. This slide is showing the same sort of concept, but the percentage of enrollment in a 4+ star contract under those 3 different scenarios. So I'm only going to focus on the left top 10 side and the small less than 20K member plans. But so we're sort of looking here at the largest top 10 MA providers that were shown in that prior graph, like Kaiser, United, Humana, and then the small, less than 20K, more regional plans. When we look at the impact of Tukey, it was roughly 10 to 12% for both of them. That's the decline of Tukey alone. But then if you go into the blue bars, you'll see that the top 10 were able to rebound from that Tukey impact. My theory is that they saw it coming. They have big stars teams. They knew they invested heavily in offsetting what was going to be a very negative impact of Tukey. For the smaller organizations with less than 20,000 enrollees, that offset never came. So what the overall impact of Tukey has had is very much widening the disparity of 4+ star contract enrollment between the top 10 and the small, more regional organizations. I'll just quickly touch on this, but when we talk about the measure, because Tukey is applied at the measure level, it does not have the same impact on all measures, and certain measures were far more impacted, meaning that those certain measures had tended to have more contract outliers. What we see is that those are HEDIS and administrative measures. That's expected. That's where Tukey sort of hit the most. And this is sort of saying, even if you as a plan changed nothing about what you were doing, you managed to keep the same rates, you kept doing a good job, maybe you even slightly improved in rates, the uphill battle that you're facing just got a lot harder because the cut point for the star rating that you were receiving could have shifted very far upward in these measures. And finally, I'll touch on cut point guardrails. So if you look at year-to-year 23 to 2024 guardrails, you see very, very wild swings, far bigger than what I'm showing here. What I'm showing here is normalized for Tukey. So the way that CMS actually applies guardrails is net of any methodology change. But if we look at that, if we look at the cut point changes year over year, even after accounting for Tukey, we are still seeing a decent amount of cut points hitting those guardrails. Those are the yellow lines at plus 5% and negative 5%. So when you see that, that means guardrails are still having an impact. Guardrails are still keeping cut points from moving more than they could. CMS has proposed removing these guardrails. So the point here is that guardrails, if they do that, it will have an impact on star ratings. And guardrails are generally keeping measures from moving down more than they're keeping them from moving up. So there would have been an even more negative impact on star ratings this year were it not for guardrails. For those of you that are really eagle-eyed and you see that 1-2-star cut point change that's above the 5% line, and it's bothering you, that is MPF price accuracy. That is outside the line because it's a measure that just came back and the 5% guardrails don't apply. It will come back into the fold next year. All right, with that, I will pass it over to my associate, Daniela, to talk about what's coming. Thanks.
Thank you, Susanna Grace. Hello, everyone. I'm Daniela Simpson. I'm a senior consultant with Wakely. I joined Wakely about 2 years ago to work with their quality team to help plans and providers navigate the star space and inform them with just really good data and analytics. And as Susanna Grace mentioned, we are not done yet. Buckle up, we have quite a few more changes to navigate in the future years. So the timeline here is shown on the slide. The things that I'm going to focus in and talk about in the next few minutes are really around what's coming next in 2024. And two big things to call out. The first thing is the decrease of weights of CAHPS measures from 4 to 2. And the other, at the same time, you can see a change in how few critical star measures are reported, talking of the HEDIS measures specifically, like breast cancer screening and colorectal cancer screening. The breast cancer screening started this year. Colorectal cancer screening is going to move to electronic only reporting next year. And then to round everything up, I'm going to talk more about the health equity index, which even though on this timeline is showing as 2027 star rating, just because CMS likes to make things confusing on this timeline, we are really going to see that we need to start thinking about this one as early as next year. So the HEDIS is expected to play a much bigger role in future stars. 2024 measurement year starting. And the reason behind it is that in an effort to kind of prioritize the customer experience related measures, a few years back, CMS decided to increase their weight, double really their weight from 2 to 4. As a result, those rates kind of drove the star rating quite a bit. They combined, which on the slide here you will see as CAHPS and operational measures, they really combined the lion's share of the star rating. In the last few years, starting 2023, when this rating first became effective, through current, they were determining and driving about 57 to 55% of the overall rate. Given this imbalance in star rating, and also specifically because they were really more weighted, even the outcomes measures, which everyone really is looking for and thinks of them as should be the highest weighted measures. CMS had a change of heart last year. This was finalized in April of this year. So as of starting next year, we're kind of going to go and see things going back to normal where they were before 2023. And with that decrease, the shift between this domain is going to be more evenly distributed. However, we're seeing that HEDIS will really drive uh, the ratings quite a bit more than they were in the past. We're seeing 10% increase and probably leading the pack here in terms of the focus of the star ratings in the upcoming years. So as we are increasing the weight of HEDIS, NCQA also made a huge big announcement a couple of weeks ago at the Innovation Summit. They have talked about the future of HEDIS being digital for quite some time now. We now have a roadmap and a timetable. By 2030, we are thinking HEDIS probably is going to be digital completely, so no longer traditional reporting will be available. And while this change deserves a webinar of its own, and probably 2 or 3 hours, we are not going to touch on that because we do have some runway to tackle this. But there are certain things that will happen in meantime that will put more pressure on health plans and how they're performing and thinking about star ratings starting as early as next year. So focusing here on the middle section where it says next, the hybrid data collection methodology will be sunset, measure by measure over the next few years. It started with the breast cancer screening last year. We're going to see it with the colorectal cancer screening in 2024. Now, breast cancer screening is administrative, so it's kind of NCQA through as a softball, just to kind of adjust and get our feet wet with this change. The hybrid measures are completely different story. Like if breast cancer versus softball, this is definitely a curveball. And why is that? So for those of you on the call who are not really familiar and haven't had fun in spring collecting medical records for your hybrid rates, this reporting is really available for measures that require clinical data to calculate the rate, or at least to calculate the really, really good rate. And this clinical data, as we know, it's kind of almost blocked, if you will, in the EHRs. We don't have the interoperability that everybody's looking for and would like to have. So when health plans submitting their data based on claims, they really cannot submit good data for these measures because they're not really part of the billing system. And just so you understand which those measures are, something like think of the diabetes measures, and the A1C comes to mind, hemoglobin. That measure, when the health plan gets the data, they really get the code that tells them that they have performed that service. We are starting to get through CPT2 codes a little bit what those results, or at least the range for the result is, but not enough. So in order to overcome these shortcomings, NCQ introduced a hybrid method where you can really draw a systematic random sample from your overall population, and that was 411. That was a tiny little sample for big contracts, and this is what the rate was. The rate is calculated on. So from those 411, the health plans went and also collected the charts, abstracted the charts. A lot of data is manually abstracted, and got what's called a hybrid lift. The hybrid lift traditionally, and even currently across the lines of business, but specifically Medicare, is giving a big bump in the rate. kind of maybe even a half, if not a star rating higher than what the administrative or full population rate would be. So with the new colorectal cancer screening measure coming in a study NCQA published a few years back for the Medicare Advantage, that's about 5 to 10 percentage points. There are some measures that are really 100% driven by hybrid. So given that we are seeing more and more hybrid measures entering the STAR world as electronic only, the number of charts the health plans need to collect, and also the number of manual abstraction that needs to happen, given the big eligible population that some of these measures have, this is going to become quite a burden, and it will require changes in how we are collecting the data and how we're ingesting it and calculating it. And just to understand how important these measures are, I mentioned 27% of next year's star rating will be driven by HITIS. Well, hybrid is going to be 16% of those 27. So the main point here is that your full population data collection will be super important in order to navigate the next to be successful in the next star ratings. In addition to that, Health Equity Index is going to be introduced in 2027. Now, this index kind of aligns with the CMS strategy to advance health equity and to attain highest level of health for everyone. So in order to achieve that, CMS, or one of the ways to achieve that, CMS will replace the reward factor with the Health Equity Index. So the reason why this will be important as early as next year is because this index will have a 2-year look-back period. So the first year that will inform the 2027 results is going to start in 2024, and also we include results of 2025. It is really intended to improve care among the historically underserved population who have higher unmet health needs afflicted by social risk factors. And for the first year to kick this off, those social risk factors are defined similarly as the categorical adjustment index for those that are familiar with this methodology. So the members who are dually eligible, who are disabled, or receiving low income subsidies. So important to highlight here that CMS is finally taking a different stance when it comes to health equity. The categorical adjustment index is really just adjusting the rate, recognizing that it's really harder to provide care and also to have good rates when you're serving population, especially when you have a large percentage of them in your population. So they will kind of give you a break. Well, this one is intended to raise the floor. So this is like, yes, we do recognize it's harder, but it's also, we would really like to focus on improving the care, just not accepting the status quo. So in that sense, with that goal in mind, you're going to have to focus on two things. First, enrollment is a huge big part. How to go about it, the slides kind of goes into detail here and explains it, but one thing you may want to, as a takeaway from here, is the enrollment is going to matter. The thresholds are basically the median, and the enrollment compared to the industry standards. So in the simulation that was given to us, the threshold to get a full reward, you had to have 41% of your membership coming from SURF. If or for the half million, that was around 21%. This was a few years back. The enrollment, as Kevin mentioned, for Medicare Advantage has grown. The SNP part of that enrollment has also increased. So as we are looking for next year, what those thresholds are going to look like, it's not, we can fairly assume that it's going to be much higher than 41. So in addition to having sufficient population, you also need to perform really well in the rates on the care that you're providing to these members. And in CMS style, this methodology is kind of kind of complicated. It's if you need help with this, let us know. As Jenna, we're happy to help you. But the goal here is really you need to be in the top third, or at least a score of 0 in order to qualify for the index. So a couple of quick thoughts here when it comes to the health equity index. The enrollment, I can't stress this enough, is important for the denominator or like to qualify, but it's also really important for the score because of in order to have credible denominators. If you remember, HEDIS has like this 30-member threshold in order for you to have a measure that's reportable. So that means that you have to have a sticky members. So the stickiness of the members will come into play in the score calculation because you're going to need at least half of the measures in order to be able to get this index. So conditions like prevalence, diabetes, and so forth can also determine your score. This index will change who is getting this reward. In prior years, the reward factors were really it's known as a 5-star maker. Those plans typically did not have as many disabled, low income, and also enrollees in their population. With this being really a main part of the index, we can see a shift of who is getting this index going forward. And I know we threw a lot of data at you so far, but if you're going to take something away from this presentation, I would focus your attention on 3 things. First is mind the cut points. A lot of plans use historically, like prior year rates to measure their success. They're not good benchmarks. They will be even less good benchmarks if the guardrails are to be removed. Susanna Grace mentioned about what that's going to look like, but 2P alone is really not going to be enough for you to predict your rates and be able to have really good benchmarks for the following years to come. The next one is stratify your rates, and slice and dice them any way you can to understand your members. But at least slice and dice them based on the socially vulnerable population. You need to understand your enrollment eligibility. You need to understand your performance for all the measures that qualify for the index. And if you're seeing that you need to ramp up and change and revamp your strategy about outreach to be more culturally sensitive and more maybe culturally tailored, to understand what are the challenges that members are facing when they're getting care, whether that's food insecurity, housing insecurity, transportation, and so forth. It's really, really important to have an outreach that will help you close these gaps and look at this strategy from that lens. And lastly, it's just do not rely on hybrid lift. It's going away. So it's going away as early as next year. I think eye exam is next in line, diabetes and hypertension are probably what NCQA has hinted going to be next. So look at your full population and focus on collecting data for the entire population. We have some really important rules coming down the pipe. The interoperability, if now looked at your OMB, will clear probably right in time for Christmas. And that will help you get the data you potentially may need, and something we have been looking for in many years in this quality space. And with that, on how to kind of go about your whole person holistic view in closing care gaps, improving star ratings, and also really curbing cost of care and improving quality. I'm going to hand it over to Kevin.
Great, thanks, Daniela, and thank you, Susanna Grace. I'm going to talk about reporting optimization rather quickly. But I think it stopped at a perfect spot where Daniela was talking about stratifying, right? And this really isn't different than other stratifications that you're doing, but it's the importance of pulling it all together, right? The STARS team can't be working in a silo, although we know what the cut points are, we know what the measure weights are, we know what the definitions are. We want to surface that up, and we want a holistic view of that member, right? So it hasn't really changed. You need to understand your members, as Daniela was talking about, right? Do they have food insecurities? Do they have transportation issues? We have a lot of methodologies and trigger points to stratify them, including STARS, but we want to understand all that. You want to target the appropriate people with the correct interventions, and then measure, trend, and repeat. We talk about how the measures are changing over time, right? We want to be on top of those for sure, but just from an algorithm perspective and what is actually working well, what doesn't work well, what's the ROI? Again, it's kind of that framework of ongoing iteration and outreach and what works. And this is where we're talking about really the member 360, right? And this varies by plans about what data sources they have. And specifically here, we're talking about STARS, but we don't want to isolate the STARS by themselves because people are more complex than one measure and one metric. We know what that metric does to our STAR ratings, but what is their marital status, their age, their gender identity? Do we have economic information? Do we have food scarcity information? Do we have social vulnerability, gaps in care, STARS, other gaps in care? Do we know anything about their diet? So looking across all of the data sources that we can pull in, and this can be, obviously claims is what we're looking at for sure, right? But we can bring in survey data. We can bring in publicly available data. We're bringing in publicly available data for our clients. We're geocoding where the member lives and appending that information to give new insights to our health plans so they can look at the social risk. So assessing all the different data points that I can have, but again, looking at them holistically. That STAR measure is one gap, but looking at the person as a holistic is how I'm going to close that gap faster, right? So what do I have? I want to have a data model that can bring in all of these different data sources, but I also want analytics that can pivot and build upon that. So where to begin? And again, we're going to be talking STAR specific, but again, from that holistic perspective, I've just brought in a model here because it's a good client example, and this is what clients were saying to us, is that we have amazing analytics. I know what their risk of hospitalization is. I know open gaps in care. I know if they have a gap in coding. I know if they had a flare-up of a chronic condition. There's a lot of data points. Where do I start, right? So from that outreach perspective, this is a model we created, but again, I'm just using it as an example of stratification. We created a population classification model to stratify the member on where they are in their current care management journey, right? So if I'm looking across Frank and I see he does need an eye exam and he's diabetic and it's a STAR measure, what else is going on with Frank that would tell me where he is in his care management journey? Does he just need engagement with the primary care, setting up the primary care? Maybe he's only going to urgent care or he has no claims at all. Does he need care coordination? Does he need to support treatment navigation? Maybe he's looking at a hip replacement, all the way down to crisis management. So by stratifying the population into a mutually exclusive bucket, you can tell the people who are going to take action, whether it's your provider, care management, member services, where this person is, and that will guide what the outreach is. And so if we're looking at that eye exam as an example, depending on where that person falls, that's going to change my strategy for outreach for this member. And I did just want to touch again, just because I know that we have many health plan clients, and we create models for them. They build models on top of our models. They use our models as an input, and they create their own models, right? I know that health plans have very strong data science teams. So I did want to bring up the machine learning as a best practice here, right? And the model I just went through uses machine learning for assignment. So you want to leverage AI to accelerate the time to insight, right? And that does not take the place of the clinician at all. I can tell you, like this particular model, we use machine learning to build it out and to build the categories, but our clinicians were there every step of the way with review. And even two of the categories we had the clinicians hand build because what we were getting from the machine learning wasn't working. But that machine learning very much accelerated the time to build this out. And you're looking at all these different data points, and this isn't all inclusive at all, but the disease characteristics, the patient use and patterns, Are they on opioids? Patient use complexity. Were they just discharged from the hospital, right? It's all those different data points. Using machine learning to get you there faster, and then using your subject matter experts who are clinicians and star rating experts and what have you to review and fine tune, again, is the best practice that will get you there faster. And this is why it matters, right? So we have 4 different people who have an eye exam. And Daniela and our weekly team talked about the different, weights and what have you, and the importance of this, and even the eye exam specifically, how the metric went down. And we wanted to do our outreach for the eye exam, right? But if we have Frank who needs care coordination, he has multiple chronic conditions. He has hypertension, he has diabetes, his diabetes is advancing. He had an uncontrolled diabetes episode that put him into the hospital. So he is not currently in care coordination right now. We bring in the participation data into our databases, and he needs outreach, he needs to get into care coordination, right? Where we see this person here, she needs support. She's individual living, well-managed. She has a significant chronic condition of diabetes, but the severity is not high. We want to prevent flare-ups. We want to prevent the progression of the disease, but she needs disease-specific advice and information. She does not need to be in care coordination right now. And we have crisis management in the lower corner, right? When we're talking about an eye exam and we're talking about sensitivity, whether it's cultural or medical or what have you, this person could be at end of life, right? This is disaster control, end of life care. If this person has advanced stage cancer, they are in hospice, or perhaps they are at high need for palliative care. I want to know that, and that reaching out for an eye exam isn't even appropriate, right? But they do need other services. So that holistic view matters very much, and we want that star piece to be a component of the overall algorithm, but not, again, in a silo. If I just ran my star measures on here, I can go and do my outreach, right, and tell everyone they need an eye exam, but it's not going to be as successful, and it could even be, offensive depending on where the person is. So we want to be able to pull in all of those different sources. And I did just want to talk about, even though we're stratifying by those 10 different categories, we want to stratify within the stratification, right? There's a lot of different, again, data points that we want to be able to take in. And this is something we work with clients as well to cross-stratify. So when I talk about cross-stratification, I'm talking about, care coordination, right? So if I'm running my entire Medicare Advantage population through that algorithm, everyone's going into one of 10 buckets. I could have 50,000 people in care coordination. I don't have the nurses and the clinical staff to manage 50,000 people. Where do I need to focus, right? So I want to, within that stratification, I want to further stratify on where my highest opportunity is, right? And so this is an overall opportunity score. It's just an example. And the nice thing about it is it can vary based on what the client's needs are, what their data sources are, the models they have in place. But we also can bring in star specific. So what it does is it gives you one overall opportunity to say, I have triggers of ER, I have triggers of gaps in care, I see they're high risk of an avoidable admission, what have you. And you're going to get one holistic score, but I have my subscores, right? And I want to be able to create a star-specific criteria that can feed that. That way, I'm able to filter on my stars, depending on who I'm talking to. I know exactly the impact that this star metric will have for me, but I also know everything else that's going on with that. And that social risk as well, that third bucket, looking at the social risk to isolate the populations we're talking about, right? Danielle was talking about the health equity index that's coming. I need to get in there early. I need to set this up so that I'm ready for that. Health equity is a huge issue and a huge spotlight on it with COVID. And we know that we have plans in place and they have health equity officers and teams. We want to work with them in order to do that. So I have my overall opportunity score. I'm going to bring in my different metrics here, and I can create, again, my star-specific one. I know what my measures are. I know what my weights are. I know what populations that Danielle was just talking about with the health equity index. I can create that. But again, it's not in isolation. It's a piece feeding this, but I'm still going to surface that star score so when I do outreach, it makes sense. The other thing I just want to mention on this is really the timing as well, and this is a best practice as well, and I know it won't be a surprise for any health plan, is the frequency you're running it. So we're running stars measures right now. We have an engine that runs analytics on demand. So a client may not need their entire database rebuilt every night, every week, what have you, and running all these measures, right? But I need to refresh my gaps in care more often. So for example, a health plan we're working with, we are refreshing monthly their database, but we run their STARS measures on a weekly basis. We can even do it nightly, right, because it's on demand. So when you're talking about your opportunity score, you're talking about your outreach, you want to really look at the frequency and work with your IT department on that as well. And with that cross-stratification, just to give you a visual of that, right, what that will give me then is if I have coordination, again, this can be your model on the left, right, and whatever, however you're stratifying today. But within care coordination, again, I don't have staff to go out and outreach 50,000 people from my care managers. I could do it digitally. So my 4s and my 5, perhaps I have 5,000, I have 10,000. I have a different level of outreach, and then I have a digital strategy for the people who are at the lower opportunity. Again, that cross-stratification will really allow you to do the outreach appropriately. And again, the STARS is a component of that, but not in isolation. And then this is just an example of an opportunity score report. And there's more metrics that you would pull onto this. And this is something we've gotten feedback from plans and providers quite a bit, is that holistic view, right? And providers for sure have complained to health plans, about the number of lists they're getting, right? So I have my HCC list for, undercoding for my ACA, for my Medicare Advantage. I have my gaps in care list. I have my readmission list. I have all these different lists coming out, and I could be getting, 5, 10 different lists from a plan, and then I work with 10 plans. I work with 15 plans. It's really not manageable, right? So if you have that holistic to say, I am looking across, we have Frank Garcia, we know what his opportunity is, we know what his risk of hospitalization is, we're embedding a STAR-specific score. Depending on who I'm talking to, depending on my mission, I can go ahead and filter on that, right? So all the metrics are there, but I have one action list as opposed to 10. And then how I'm working this and who I'm talking to, whether I'm talking to a provider, I'm talking to care management, I'm talking to member services, those messages are going to be different, but that list is the same. But the actions they take, right? What I can feed this to member services. The member services, when they call in, member services can make an appointment to say, hey, you need a new ID card? Let me make you an eye exam appointment. I see you have a gap in care. Can I help you? So that holistic view of that member from an action list is key. I do just want to talk about aligning across departments, just really quick. And I think value-based care is an easy one, but it's not just value-based care and network management. It's across your organization, right? And so another best practice is aligning the different departments. And with the value-based care, again, an easy one, if I reach out to Frank, I want to reach out to Frank because he needs to be in care management. I have one patient. Frank Garcia's endocrinologist is Sheila Jones. She has 80 patients that are part of my Medicare Advantage plan, ABC Medical Group 325. But as Susanna Grace and Daniela pointed out, right, things are changing. And the lag of that, the 2022, what happened in 2022 is giving you a star performance for 2024, and then you're getting paid in 2025. Daniela talked about 2027 health equity, but you need to start looking at data, next year, right? So aligning your value-based care contracts early with this and everyone being in line, and the quality department may be running it, right? They're going to be the SMEs. They're really in deep, but working across the organization from risk management to network management to member services, care coordination, health equity, right? We're talking about health equity, and there's divisions within a health plan now. Everyone needs to be at the table. And the last thing, and we just have a few minutes left, is IT, and IT should be there day one, right? Everyone should be there day one, but IT plays such an important role. We're talking about different data sources being pulled in. Your data model wants to be very flexible, right? IT is going to be managing that. New fields, as you're looking at being able to create new fields. I talked about running analytic on demand. Your architecture is key and your data flow is key. IT plays a key role in this. And the quality department can help educate across the organization so that you're a united team. You're meeting periodically throughout the year, and then you're getting in early. So that was a lot, and I know we're almost out of time. one thing I did want to mention, there is contact information here. Susanna Grace and Daniela have their contact information as well as some recent publications. There were some questions here about sending out the deck. We will be absolutely sending out the deck. We also have contact information for Merative as well as some of our most recent thought leadership piece. Again, we work closely with clients on STARS and have certified measures in order to work closely with clients on that, as well as the scores we were talking about. And we might have 2 minutes for other questions. All right, could you talk more about the social risk factor component of the opportunity score? Sure, so one thing I will mention is just the flexibility of that, right? It really depends on what the data the client has. Unlike a model that we have, a canned model that uses machine learning, we're building it off all the common data sources the client has. The opportunity score can take in what the client has. So, you know, we now have SDOH, ICD-10 codes, right? We have survey data from clients. I mentioned that we're geocoding our clients' data to pull in the social vulnerability index and other indicators to look at, you know, food scarcity and transportation issues and race and ethnicity. So it is going to be specific to what the client has, and then methodologies that we apply to that. So that's really the nice thing about the opportunity scores. We can fine-tune the weights, and when we're talking about STARS, we will be fine-tuning it to what is coming that Daniela touched on as well. And then one last question, what are plans doing to improve their scores? If we haven't touched on something, maybe Susanna, Grace, or Daniela, do you want to touch on something or just reiterate kind of a big impact item that we chatted about?
Sure, I'll try to tackle it in a minute, and maybe Daniela, you add a little bit of extra insights. What can plans do to improve their scores? Well, if you're talking about your overall star rating score, I'd really press that you should not look at what you have today as what you will have in 2 years. So really think about what's coming with star ratings. Think about where the concentration is shifting, and that's really just away from CAHPS and into HEDIS and into HEDIS and pharmacy measures, and really put your focus there. Even though they may not feel like the biggest measures today, they will be the biggest measures going forward, and they're also the biggest measures, the measures that were most impacted by Tukey. So I would really focus your efforts in those areas, because you're going to get I think of it as a triple bump. You'll improve in those measures, you'll improve in the improvement scores, which are really important and will become more important as the hold harmless provision may not help you as much anymore with the implication of Tukey, and you will get the bump in them being more heavily weighted in the star rating program. So that's where I'd put my focus.
Great. Do you think we're out of time? We'll turn it back to the AHIP team.
If we have time, I want to touch on one question that's about the CDS measure real quick, about removal of CPT2 codes. CPT2 codes are not getting removed. They're staying. The hybrid portion of how you report your measures is going to go away. So keep on doing everything you're doing. Increase your volume of CPT2 codes. That will help you with the rates. You just have to do it for every single member in your eligible population. You can no longer rely on whatever the sample was, 411, sometimes even small, because of your good administrative rate. You will probably have to tap into other sources just to get where you were when hybrid was available.
Thank you, Danielle. And I guess we will turn it back to Robin just to close this out then. We appreciate everyone's time very much.
To our speakers, we thank you for that great presentation and for sharing your thoughts. And we want to thank you, the audience, for participating in today's webinar. This concludes today's presentation. Thank you again, and enjoy the rest of your day.